So good morning, everybody. We're going to get started. There are people still coming in. There's over 70 people on the line. I'll just remind you that there's a question and answer box at the bottom of your panel for those of you that are on the computer. If you want to ask questions while people are speaking, you can get them answered in real time and share them with other people, as well as wait until the end. So welcome to May 8th. This is the second in what we hope to be an ongoing series of expanded province-wide rounds, currently focused on COVID and the kidney, but hopefully on other things as well. So this is from all of us to all of you, and people from around the province are gonna give some talks today. Next. I'm going to repeat for some of the individuals the fact that some of the slides that I gave last time. So I want to remind everybody that what the BC Renal response to COVID-19 represents is a rapid mobilization of quite a mature network that supported a high-risk life support population. Next. We serve BC, as you know, in 5 health authorities, 6 if you count children's, although it's not geographic, and we have 11 training sites, 12 PD clinics, 13 dialysis units, 14 CKD clinics, and 28 community dialysis units. And 14,000 people have chronic kidney disease, and 3,500 are on dialysis, and 3,500 have transplants. And so in that context, with the patients and the community at the center, we actually take care of the services and delivery of that complex group of patients. Next slide. So our long-standing provincial committees were well positioned for a rapid response during this crisis. We've maintained our focus on patient and staff safety, and I think that's a testimony to all of you who all know why we're here. And I've just listed for you, as I did last week, all the different committees. And at the top, you'll see the Emergency Management Planning Committee, which has certainly helped us, having ensured that we had a structure of some sort. Next. So this is a series of expanded province-wide rounds that are focused at this time on our collective response. Everyone is able to come. 99 people came to the first session, 130 have registered for this one, and 85 of you are on the line so far. We had amazing ratings and everyone said it was helpful. So we're hoping that as we go forward and get your ideas for more rounds, COVID and non-COVID related, that we will build a learning community over time and have yet another silver lining out of this COVID crisis. Next. So last week we talked about an overview of the current state in home therapies and facility-based dialysis. And today we're going to talk about chronic kidney diseases and the KCC response, and some nuances around glomerulonephritis and that network, transplantation and palliative care. And mostly, as I said last time, this is to answer your questions, stimulate discussion, but more importantly, to foster collaboration, if that's possible, to do it even more than we have already. Next slide. So you recall that all of us are in this together, and the lifestyle that we previously ordered is currently out of stock. And for that reason, we really need to continue to work together over the next while. And everyone that you know is affected. Next slide. Sorry, guys. This is a high-level overview of the province's emergency management structure for those of you that were not on the call last week. And importantly, it is a complex structure, and this is the one that's from March. It has changed and will continue to change as there are different phases of the pandemic, but we touch the different components in terms of planning section, health systems operations, public health and emergency management. And as an inpatient, outpatient, the provincial-wide service becomes sometimes a bit complicated to navigate. Next. The medical directors of the geographical health authorities actually meet on a regular basis, and we all have to operate within a provincial, regional, and institutional context, if you will. But importantly, by linking with the executive admin, the various provincial committees, the stats and methodology group, and Promise, we've actually been able to have a lot of timely communication, share decision-making, and continue to work together in this rather interesting environment of COVID-19. Next. John, Melanie, Mike, Marie, and Anurag are the medical leads, and the responsibilities they have are diverse. Never have any of us been to so many meetings without leaving our offices, and yet actually have accomplished a fair bit. Next. So what we're going to do today is Mike Bevilacqua and Sean Barbour are going to talk about the KCC and GN response. Gaylene is going to talk about palliative care, and Jag about transplantation, not quite in that order, unless somebody switched it on me. And then hopefully, if we all keep to time as we have tried to do, we're going to have questions and answers at the end, again, both in real time as well as at the end. So thank you very much. I'm going to hand it over to Mike and then to Sean. So thanks.
Sorry, I was still muted there. Great, thanks, Adeera. Yeah, so I think we'll take through the KCC response. Maybe I'll just start by preempting the most common question of, yes, I did have to shave for all this, and no, I do not like it. So we don't have to type that into the question bar there. So if we go to the next slide, we'll take you through this. So to start, I just want to echo what Adeera said, that this really was a big team response. And frankly, I don't think it would have been possible to respond as quickly and robustly without the existing structure we have in place. I tried to include as many names as I could here, but frankly, this was everyone's work to put this all in place and to keep us moving forward as this evolves over the course of the next 12 to 18 months even. So if you go to the next slide, Brenda. I'm not going to read this all out, but this is just to remind everybody that we do have very set goals of care and values set for our KCCs. And we have this for most of our committees. And I think this is important to remember as we chart out our response over the coming year, that whatever we're doing is aligning with our established goals of care. If you look at these, they're broken into bullet forms, but really you can split this into what we do in the Kidney Care Committee or in the kidney care clinics, which is monitoring, self-management and maintenance of our patients is one big chunk of work. And another big chunk of work that we do is helping our patients to navigate both the system itself as well as transitioning to treatment modalities. So this is under usual business what our goals of care are. And if you go to the next slide, Brenda, we can map this out to our response to this current crisis as well. So we do have a few items that fall under the umbrella of maintaining our patients and keeping them well. And then we have other items that fall under the umbrella of helping them navigate the current services and transitioning onto their desired treatment modalities. There's kind of 5 big categories here, and I'll take you through each of these, as these are kind of our pillars of how we've laid out our response to this within our kidney committees. So you go to the next slide, Brenda. One of the biggest items that's maybe a little different than we heard last year is in the kidney clinics, it's really trying to do business as usual. What we heard last week from things like hemodialysis and home dialysis was really about dealing with surge capacity, trying to keep the lights on in a new environment, keeping our patients well. Whereas here, it's about maintenance. It's about trying to maintain what we already do, because what we already do is support a huge number of patients at home. I put these numbers here because it's important to reflect on just how many people we care for. And the most important thing to remember is that keeping these people stable is what keeps them well and what keeps them outside of the hospital. So carrying on with those services is crucial to a very large number of patients. You go to the next slide, Brenda. So the first order of business was to try to figure out how can we provide this care in a way that's safe for our patients and in a way that's safe for our staff. It was a very quick transition when this all came to doing virtual visits. Within literally 2 business days, we went from having phone calls about it to basically every kidney clinic in the province having their visits being done remotely rather than in person. Right now, it's being done in a variety of ways. What we can say from across the province is it's essentially exclusively or almost exclusively by phone calls. There's different staffing models where some people are like myself. I'm the one with the pants on, by the way, not the one with the pants off, but like myself, doing it from home with a phone call. Some people are going into a clinic. There's some combination thereof. And that's really based on whatever makes sense for each clinic. So there's flexibility built into that. We've provided some guidance initially about how to screen and figure out who's coming in for physical visits versus who's being done remotely. But really the fact of it, as we talk to people, is that very few physical visits are actually happening. Right now, it's almost essentially virtual and by phone. And this has served us quite well for the first, kind of 6 weeks of this response. It's made us able to carry on with seeing our patients. If we go to the next slide though, Brenda. Oh, you're thinking and anticipating beautifully. But now we're thinking about how do we move into what is this new normal? So, phone worked because we could all do it. It did not require anything new either on our side or on the patient's side. But now we're really thinking about how do we have something in place that's going to serve us into the future? And we're really looking at virtual options, things that involve some amount of teleconferencing or some combination of things. We're looking at this, and some of this is happening in each health authority already. There's a very exciting, I think, collaboration we have with, there's an entire Office of Virtual Health at PHSA that's made for supporting essentially this work, where we're going to try to figure out things that help us see and provide more robust virtual care to our patients, both now, as in within the next couple of months, and then something that's going to work for us in the long term. You see that we have here plans with an S there, because this isn't going to be just one option, and I think that's becoming more and more clear as time goes on. There's going to be probably a menu of different things that people will be able to select for, either based on what's being done within your health authority, because some health authorities are going to favor certain solutions, or what your exact clinic workflow looks like. And having that flexibility is an important thing, which we try to do in all of our work in KCC, to let people select what works for people. As we're moving into this, I think the real thing to keep in mind is it's not just about making a video call, it's about how do we take the same level of service that we had before all of this and now apply this to a new way of delivering the care. And that's really our goal as we move through this. We go to the next one, Brenda. So that's actually seeing the patients. Another big aspect of the response has been lab monitoring. Now, the first response and what happened over the first couple of weeks was, you can essentially think of it as minimization. People didn't know what was going on. Our patients essentially didn't want to leave their house, let alone go to the lab where there was lots of people. So we kind of went through and said, well, how can we rationally decide, are there people who could safely defer their blood work? And again, for a couple of weeks or a month or that type of time frame, that kind of makes sense. But now we're kind of back into the maintenance phase, where we need to think of a way to have this done safely and sustainably. And the messages that I think we really need to stick with are twofold. One is that the labs very much are safe places to go for people who need to go. I've actually, those of you who know me know I have not many nice things to say about Life Labs these days, but they've done a tremendous job. All of the labs have done a tremendous job on ensuring that when patients come in, they're dealt with safely and appropriately. So the labs are safe places to go. And the other part of this message is that keeping people safe and out of the hospital, lab monitoring is an important part of that. Right? For our patients, if we don't know what's going on with their blood work, we don't know if they're doing well. So a couple of visits to the lab is very, very essential to keeping them safe. And I think as we go into the new normal, what we were doing before with lab work is very much what we should be doing now. It just looks in like a little bit of a different format. So if you can go to the next one now, Brenda. The last pillar of what we were talking about in the KCC is preparing and transitioning to treatment modalities. And a few things fall under this. One is modality education. Now, we already have a lot of online tools. We're lucky that we have this, and we're well ahead of the curve. We have PowerPoints and videos that our patients can go to online, so that already exists. This is still a bit of a challenge, though. This is one of the areas we've heard is a little bit trickiest, where that personal touch, that one-on-one visit, seeing somebody, seeing how they react face-to-face is a key part of the modality education. So we really are trying to enhance this. We have a webinar, which I'll talk about in a second, that we're using to supplement this. Transitioning, so that's educating our patients. Getting them onto their dialysis modalities smoothly is another huge thing. And again, a selling point here, because doing this well and doing this smoothly avoids hospitalizations. It keeps our patients well and keeps them as outpatients. It's worth pausing and talking a little bit about dialysis access, because this is an area where there's been huge success. I never would have thought, frankly, this would have gone quite as smoothly as it did. where we've been able to both prioritize dialysis access and actually get this done, even in the midst of ORs everywhere being shut down. That's a tremendous accomplishment. A lot of people, John Antonson took the lead on this, and a lot of people in every health authority did some huge heavy lifting to make sure that this has happened. And it's tremendous that people are actually, despite ORs being shut down, are getting their fistulas and accesses created. If you don't mind going to the next one, Brenda. This is what I was talking about with modality options. So it came out loud and clear from our committees that as this was a challenge, we're trying to supplement this as best as possible. So for the first time ever, later this month, we'll be offering a province-wide webinar meant to supplement the modality education that patients are having at home. So patients, their families, anybody who wants to can attend this. And we'll likely be doing this on a recurring basis to supplement what's going on. So make sure you advertise this. Transplant and conservative care, you're going to hear more about this later on. I'd say in short, from the KCC standpoint, it's been a difference in messaging, a difference in how do we keep plans moving forward and have patients adhere to their plans in a very different environment. Okay, so I'm going to skip over this. We'll hear more from these groups in a second. And then the last couple of items I want to talk about is making sure that we can keep everything going. And this is looking into the long term. You know, for other committees, I think it was really first planning for the worst case scenario. That thankfully has not occurred. Now we're in the point of saying, how do we keep our services running? How do we keep our staffing up? How do we make sure we're at the same level of service, but in a different format? And the administrators group around the province have done a great job in doing this. And this is really going to be the key of everything that we do moving forward. If you go to the next one, Brenda. So I think, you know, just to wrap this up, we've touched on most of this, but when we think about what the new normal looks like for KCC, I think there's a few items that come up. Really think about, we're going to be looking at a clinic structure that's going to look different than what we had in the past, but it's going to be a way that we continue to see our patients, likely a hybrid, combining our old and new workflows into something completely new, but that offers the same level of care. You're going to see a whole lot more about virtual health. And we're starting to get back onto track into getting some of our key tasks moving. Access is something we're going to keep hearing about in coming months, and we're going to come up with a plan as the ORs turn back to normal service. And then lastly, Brenda, if you go to the next one. And then I think this is something every committee's thinking about now is how do we get the previous work that we had going before all this back on track? The one that you'll definitely hear a lot more over the coming months is Transplant First. This is our largest body of work. It will continue to be our largest body of work over the coming years. It just might look in a different format. So with that, I'll kind of end it. I just want to say, if you go to the next slide, Brenda, say again, a huge thank you to everyone involved, because this all would not be possible without the great committee members we have. And now I'll turn it over to Sean to talk about GN.
Thank you, Mike. I'll just elaborate a little bit more on what Mike has said from a GN-specific point of view. So the first issue the committee addressed was, do we think that the risk of acquiring SARS-CoV-2 or having a serious complication of the infection might be increased as a result of immunosuppression used to treat glomerular disease? So unfortunately, there's not a lot of great literature to guide on this. There is, however, some reviews of literature taken not just from COVID-19, but also from related coronavirus infections during the SARS and MERS epidemics that were largely based on transplant patients. And in this literature, there was really no clear signal towards an increased risk of acquiring the disease or of having a serious complication of the disease as a result of being on immunosuppression, at least in the context of transplantation. However, on the flip side of that, though, we do know that there is clearly increased risk of other types of viral infections related to immunosuppression, as well as we know that the uniform treatment of SARS with corticosteroids actually seem to result in worse outcomes. Next slide. So on the balance of the available literature, which we acknowledge is not great, we felt that we had to consider the risks of withholding immunosuppression, which could and likely would precipitate disease flares that may accelerate progression to end-stage kidney disease, requiring dialysis and therefore resulting increased utilization of healthcare resources that could become very limited in the context of a huge COVID disease flare. In addition, there's the risk of extrarenal disease flare in diseases like ANCA or lupus that may themselves precipitate hospital admission or even ICU admission for severe extrarenal disease. So on the balance of these issues, we came up with a recommendation that was really against the routine reduction of immunosuppression for the purposes of preventing SARS-CoV-2 infections in patients with glomerular disease. We felt that each patient, of course, should be considered individually and that immunosuppression could be reduced, but only if it would be clinically indicated otherwise. And we felt that this was really a consistent recommendation with what BC Transplant was also doing at the time. Next slide. There also arose an issue around access to medical short stay for IV immunosuppression medications. And as an extension to what I just mentioned, induction therapy with IV corticosteroids, cyclophosphamide, or rituximab would clearly not be considered elective in order to prevent disease progression or even severe extrarenal manifestations. And so we made it clear that access to IV immunosuppression needed to be maintained and continue throughout the COVID epidemic. Now, in terms of other types of immunosuppression, as you know, we distribute our GN formulary medications through community pharmacies. And initially, there was a reduction in the amount of dispensed drug from our usual 90 days down to 60 days to mitigate against any potential supply shortages. Now, really, there have been no shortages that we've identified. However, mycophenolate is on what we call allocation. And I had to ask Cliff Lowe to educate me around what this actually means. But what it means is that the manufacturer has identified potential risks in their supply chain that have the potential to reduce supply and result in shortages, but as of yet have not actually resulted in meaningful shortages. Next slide. So how might an allocation arise? And so as it turns out, pharmaceutical manufacturers tended to rely quite heavily on passenger flights to move medicines or active pharmaceutical ingredients around the world. And so as passenger flights declined, they had to rely on ocean freight, which is slower, more costly, and then also the port labor has reduced, so offloading medications in the ports was much slower. Also, some countries are engaging in sort of protectionist policies and reducing export of drugs, which is relevant in Canada for hydroxychloroquine, where the majority of which comes from India, which itself, as you know, has put down quite significant restrictions on exports. So these are the different reasons why a drug manufacturer might identify a drug as being on allocation. And as a result of this, we are still continuing to reduce the number of days of dispensed mycophenolate. But I think hydroxychloroquine does require some specific commentary. I think we all agree it should not be used to treat SARS-CoV-2 outside of a clinical trial scenario. And there are multiple supply and demand issues that are unique to hydroxychloroquine. So all the allocation limitations I mentioned above would relate to supply issues. And then, of course, Donald Trump's sort of Twitter-based endorsement of hydroxychloroquine has really driven up demand for the drug. And the drug is really not very expensive. So at 50 cents a day, if you alter funding policy for hydroxychloroquine, you're really not going to alter utilization because patients can just pay out of pocket for hydroxychloroquine. So now, fortunately, as of April 23rd, the drug was not considered to be in short supply. However, we do anticipate that prices will likely increase as a result of the imbalance between supply and demand. And this will actually probably put real pressure on patients who do legitimately need the drug, such as with lupus or other types of autoimmune disease. Next slide. In terms of kidney biopsies, I mean, I think it's pretty common sense that if it's really not an urgent biopsy, this could be delayed. But any biopsy that has the potential to alter treatment, we felt should continue during the COVID pandemic. And as Mike mentioned, patients have a lot of questions about going for blood work, and the labs are a safe place to go. We've been advocating for patients to use preferably community labs for situations where you're using the labs to monitor disease activity or for drug safety, which we felt really were not elective-based lab procedures and should continue. Next slide. Thank you.
You have to unmute. Oh,
Yes, I've unmuted now. Thank you. It's a rookie Zoom error. Good morning, everyone. Adeera asked me to give a bit of an update on behalf of the transplant group. A lot of the issues that were brought up, actually, importantly, by both Mike and Sean, are relevant to the transplant population as well, as you can imagine, both in terms of the ambulatory care management, as well as in terms of the role of immunosuppression and management of our patients during the COVID kind of time. What I'm going to focus on, just in the interest of time, really is around the bigger question, which tends to come up and has been kind of dominating a lot of our discussion, is what happened to transplants in terms of the actual activity of doing transplants and what some of the decision making has been in terms of moving that forward right now. So we can just start with the next slide. So in terms of the impact on transplant patients, just to get people up to speed in terms of what has happened, as many of you know, when things started in mid-March, the National Kidney Pair Donation Program suspended its activity around March 15th, and that directly impacted us because we had a pair scheduled the subsequent week. We were at the tail end of a chain, and so one of those transplants were canceled. There was still discussion on what to do with directed donation as of that, the end of that week, and we had a transplant booked on the Monday that we went forward with, and everything went fine in terms of that. But that was the last one that was done in the country, after which there was essentially a nationwide suspension on living donor transplantation. The rationale, again, being mostly around the safety concerns for both donors and recipients, and also some of the issues around hospital capacity, as hospitals around the country were really trying to whittle down the number of elective surgeries being done. In terms of deceased donor transplantation, we proceeded with what we're calling a modified selection of deceased donor kidney transplantation on March 18th, we basically restricted it very much to patients that were highly sensitized at that point, really assessing patients' urgent need one by one, and that's kind of what was being done at that point. From an ambulatory care perspective, as I said, as happened in KCC, we had to very quickly move to a greater than 90% of our patients being seen virtually in post-transplant care. That's a huge volume of patients that we see on a very regular basis, and we had slowly started to transition, at least delay visits and do telephone visits even leading up to this, but this was a rapid shift, and so really it was to the credit of our nursing staff and our multidisciplinary teams that was actually feasible and actually went without any significant hitches. Our nurses really picked up an extra load in terms of calling patients and helping with triaging those calls and those things. Pre-transplant assessments were halted for about a week. And then we actually started to continue with our pre-transplant assessments virtually, largely restricted to patients that had been previously seen but still hadn't completed their workup, so that we could move those processes along and communicate with patients. Also with touching base with all the patients whose transplants were potentially scheduled or were canceled, so that we could get some plan in terms of moving forward. We, as a group, so Alwyn and I have been on these national calls with CBS and Canadian Society of Transplant and Health Canada, where there was initially twice a weekly call, and now it's weekly, where it was looking at national consensus guidelines about what's happening around the country in terms of donation and transplantation. There's a group from there that meets with international colleagues every week, and so getting updates on what's the international status in terms of transplant activity and services and complications with COVID. Obviously, we work with BCT on a regular basis to provide some sort of support and education to the prevalent transplant population, so there'd be consistent messaging from BCT as opposed to ad hoc messaging. We had to quickly put together what we're calling COVID clinics, which thankfully have slowed down a little bit, but for the first few weeks, there was, as we all know, tons of frantic calls from our patients. And we were quickly realizing that 811 was not really meeting the needs of many of our patients. And so we essentially had them all triaged to us and informed our patients to call us. And we did a lot of the COVID screening organization, as well as follow-up of those patients. And then, of course, weekly meetings with regional reps and those kinds of things. Now, one thing we've kind of done in the last few weeks is we're now meeting weekly with regional representatives from all of the health authorities, specifically around transplant issues. As everything is, it's been COVID heavy, but we had a couple non-COVID questions yesterday, and it was really fun to talk about something other than COVID. So that's where we're at there. Next slide. Now, I thought it'd be worthwhile to go through how many people we've kind of heard from, how many patients. This is just St. Paul's VGH, and there's been a few additional around the province, and this includes Fraser as well, actually. But basically, there's 44 patients that we've been tracking. So we've been just keeping track of this, of all the calls we're getting, and all the patients we've virtually seen to assess for COVID symptoms. So there's 44 patients. 27 of those got tested for COVID, 4 tested positive. 2 people passed away, and 2 of them were discharged from hospital. There's another presumed COVID case that was in hospital, actually, just I found out yesterday, just discharged. There were 6 COVID negative patients that were admitted to hospital for what's felt to be non-COVID related issues or unknown issues. 2 of them were in the ICU. There's 1 unwitnessed death, and so thinking about unintended consequences of not maybe seeing our patients as frequently, that had nothing to do with kidney disease, it sounds like, and nothing to do with COVID, but nonetheless a sad event when we find about that without having to see our patients in person. Next slide, please. So we've kind of put together a staged timeline for transplantation activity, and so I'll just kind of quickly walk you through this. It's a 4-stage event, but we start with stage 0, which is where we had been much for the month of March. And we've kind of defined these stages, and this is what most people in the country are doing, some sort of a breakdown of this. We don't have great quantitative measures of these stages. There was some thought put into looking at the kind of epidemiologic numbers that you could into looking at this. But broadly, stage 0 is when we were in this past month. So community spread was existing. There were a growing number of active cases. During that time, as I said, living donor transplant was suspended, and we were doing very selected deceased donor transplantations, essentially those that were HSP and those who had medical priority. Stage 1 is community spread exists, but there's a stable number of active cases, and that's kind of where we are now. So decreasing hospitalization, but not a huge growth in the number of new cases that are coming every day in the province. Stage 2, which we're not there yet, would be a low number of active cases and low community spread. That's pretty generic in terms of the way we're defining it, and I hope we'll figure it out when we get there, but that's kind of where we're at. And then the last stage is kind of where we were kind of in terms of the real normal, and that's kind of the next phase. Next slide, please. So in terms of deciding what we do for each of these stages, there's obviously a number of kind of guiding principles. And, we all appreciate this, but it's worth kind of listing some of the key points here. So obviously we know that kidney transplantation is life prolonging versus life saving. And so that for each patient, as we always do, we really have to consider the benefits, and that has to outweigh the risk in the current state of COVID. And that's challenging because we can't really quantify that risk in the current state as well as we have for other risks. But we also have to consider the risks that patients have when you delay transplantation, and so that's the other important consideration. Obviously, in order to actually move things along, we have to have rapid availability of testing, which thankfully we do at this point. Recognition that our traditional allocation policy may need to be modified to mitigate some of the risks, or some of the patients that we had approved previously may not be eligible in this current climate. From a kind of a process perspective, we need a COVID-free pathway for patients both while they're in hospital as well as during their outpatient care. I don't know that we can ever get a true COVID-free pathway, but at least a COVID-light pathway so that we can restrict their access to patients and that kind of thing, and environments which would increase their risk. Virtual care obviously is going to be an ongoing critical component right now. And then we need system and hospital capacity with appropriate PPE and everything that entails to make sure that we can actually provide the care safely. And then lastly, but not, but certainly importantly, I think, is that we need some sort of monitoring of this process. And so we have to embed CQI in this so that we are looking at both how we're doing, how well we're adhering to what we're trying to do, as well as looking at any unintended consequences in real time so that we can quickly course correct. Next slide. So this is what we're doing for deceased donation. So stage 0, which is where we've been, has been kind of, for donor acceptance, we're really just restricting it to NDDs, so brain dead donors, and the very odd DCD. And what I mean by that is, so if there's a highly sensitized patient, then obviously we expand the criteria a little bit of the types of donors that we would be considering. So we are hearing every offer as it stands right now. We haven't kind of said we don't want to hear your offers. We're getting every offer, but these are generally the ones we're accepting. We're being restrictive in terms of AKI, which normally we would not be. And the rationale for all this really is to say we obviously want to minimize exposure to prolonged exposure, I should say, to hemodialysis units after transplantation, acknowledging that that's a higher risk environment, and if patients have to go there repeatedly on acutely post-transplant on immunosuppression, that's probably suboptimal in this early stage. And then the other important thing we have to do, obviously, is avoid donor-derived COVID. Now, importantly, internationally, there's no known cases of donor-derived COVID, as far as we know, but the precautions that are being taken across the country are that there is a questionnaire screening for patients who are at risk, for donors, I should say, who are at risk of COVID. There's COVID testing done. Two negative COVID swabs are done by BC Transplant through lower respiratory tract specimen. And most donors tend to get CT chests anyway, so we're also looking at CT chests to ensure there's no findings suggestive of COVID. And if all that is negative, then we're presuming there's a low risk of transmission, and therefore we're moving forward. Currently, moving into stage 1, we are really applying the same policies in terms of the types of donors that we're accepting. As we move to stage 2, we'd like to expand that to DCD and ECD a bit more broadly. And then, of course, when this thing is kind of said and done, one day, hopefully, we'd be back to considering all the types of donors that we had in the past. Next slide. So this was a tricky one. In principle, it's easy to say we're going to try to restrict or triage patients who are at lower risk for complications following transplant, and really with an intent to minimize prolonged hospitalizations. So there's no existing score that really adequately does this. Most scores in transplantation are focused on long-term graft survival, not on early post-operative complications and prolonged hospitalization. That really there are scores for delayed graft function, but really nothing beyond that. And so we've kind of attempted to, and modified this already many times, develop a recipient risk score so that we have some standardization and some transparency in terms of what we're doing. And so I won't go through this. Many of you have reviewed this with already, but basically we're lumping recipients in our existing waitlist population into 3 groups, and everyone's being assigned a score of 1, 2, or 3. 1 being your low risk population, which are your patients under 65, non-complicated diabetic patients. Doesn't mean we're excluding all diabetic patients, but diabetic patients who have other cardiac complications, for example, severe pulmonary disease, those kinds of issues. Patients who are immunologically complex and would require heavy doses of immunosuppression, and specifically would require T lymphocyte depleting agents, are considered low risk. And then from a psychosocial perspective, there has to be a process now to get patients from around the province here safely without exposure to a lot of people, keep them here, make sure they can manage virtual care. They don't have a lot of support people, you have to realize. So, there's no visitors in hospital, and when someone leaves hospital, they need to kind of have some sort of maybe single person help them out. So those are the major considerations here. And then we are making allocation decisions case by case, taking this risk stratification into account. Next slide. And then in terms of recipient candidacy, so as I said in the kind of previous stage 0, really all we were doing was the medically urgent and highly sensitized patients. We're now including everybody who's kind of got that low risk score, and then those that are above that, because we have to be practical about the number of patients on our list. We are considering case by case people who have a higher risk score than that, but the bulk of the transplants we're starting with right now are the lowest risk score, and then we'll expand that as the stages move forward. Next slide. So in terms of where we are in terms of other transplant activity, currently we're in stage 1. We are doing selected living donor transplants. And so we've got a transplant booked next week, living donor transplant. I think it'll be the first one in the country since COVID started. So we did the last one and we're doing the first one back. So thanks to everyone. And thankfully we've been fortunate from a COVID perspective that we're in a position to do this. And we're doing the deceased donor transplants in stage 1, as I said. We would obviously expand all of those criteria as we move through our stages. Next slide. Process changes I think are worth knowing for living donors and recipients. Both of those parties have to self-isolate for 14 days prior to the OR. They're getting COVID swabs prior to the OR. We're trying to shorten hospital stays down to 3 days whenever possible. And of course, an enhanced virtual follow-up. And I won't go into that in detail given the timeline here. Next slide. Nope, that was it, I guess. Yeah, so I guess the last piece I just wanted to address was around the communication around this, because that question has come up of patients are anxious, patients are concerned. There's lots of stuff in the media around access to care. And I think one of the things with transplantation is people have been scared that what this means for their access. And we've had lots of conversations with our patients. And I think the kind of communication strategy has been, we want to be consistent and we don't want to create anxiety among a patient population that is facing a lot of additional stress already in terms of the COVID. And so really the messaging is transplantation is persisting. We are continuing this. We are kind of doing this weighing case by case how we move forward. But I think the important message here is that when we're making those decisions, it's not really driven by hospital capacity. I have to say the hospitals have been really good with us in terms of capacity. We haven't had to decline somebody's purely because of a hospital capacity at all so far. And so it really is based on doing our best to weigh the pros and cons of what the best scenario is, and then have that conversation with our patients given the risks currently. And some patients are saying, I want to wait, and some patients are saying, I'd like to move forward. So that's how we're doing. And of course, it's quickly evolving. So kind of frequent communication through BCT is going to be an ongoing issue. I'll stop there. Thanks, everyone.
Good morning, everyone. Can you hear me? Hopefully. I think I did unmute.
No, you're audible, Gaylene. Just
Okay,
lean into the computer a little bit.
Okay, thank you very much for this opportunity to present. And I am presenting on behalf of an outstanding team called the BC Renal Palliative Care Committee. And so we're going to discuss COVID-19 and relevance to integrated palliative nephrology. Next. So I must acknowledge Sarah Thomas, who is our project manager and a technological wizard, because she helped me immensely with my slides. Thank you, Sarah. Sue Saunders, who is strategy lead for our PCC. Selma is our administrative lead. And Dr. Rachel Carson, Dr. Brian Forsley, and Nina Prito have been instrumental in the development of an ethical framework for dialysis allocation, which is in process, and I'll discuss that towards the end of my presentation today. Next. So in terms of context and framework, we were very well positioned, many thanks to the leadership of Dr. Mahmoud Karim. It's over a decade now since we established our 4 pillars of the end-of-life framework. And this is patient identification, pain and symptom management, advanced care planning, grief and bereavement. And I don't think anyone would dispute that all of these are relevant in the context of COVID-19. So that's what remains the same. How COVID-19 changes things is that for patients already near end of life, death may be more imminent. And so therefore, there may be an urgent or semi-urgent need for goals of care to be clearly documented or updated. Resource allocation may influence outcomes, and thankfully, and we have to thank leadership in the province, Dr. Bonnie Henry, our own leadership within BC Renal. we have to acknowledge their efforts in terms of the reason why our numbers are as low as they are. But worst case scenario is that we may be faced with resource allocation, meaning even those patients who desire life-saving therapies may not have access to them if the demand exceeds capacity. So what should remain unchanged is that advanced care planning starts with learning about patients' values and goals. What matters most to this patient? That's how we start and that's how we end our conversations. And that also needs to be documented in their goals of care documentation. Next. So if you haven't already, I would invite you to have a read of James Downer and his colleagues. This article published recently, well, it's in an online publication in CMAJ. And in fact, Sandy Buckman, our CMA president, was one of the co-authors, entitled Pandemic Palliative Care Beyond Ventilators and Saving Lives. And this is a direct quote. These are direct quotes from the paper. The COVID-19 pandemic will likely strain our healthcare system beyond capacity. And sadly, we are seeing that becoming a close reality in our provinces to the east, like Ontario and Quebec. Palliative care services will be needed across all care settings, including the ICU. I can proudly report that this was a non-COVID situation, but a patient of one of my colleagues had a very comprehensive palliative care physician consultation while in the ICU. So we should still have access to those resources. In fact, they will be called upon more extensively. Failing to provide Canadians with effective palliative care would compound the tragedy the pandemic has already caused worldwide. So the tragedy to avoid is this: patients who choose not to have life-sustaining treatment or are denied due to overwhelmed resource capacity are not provided optimal symptom control, and psychosocial supports are inadequate. Quite simply stated, they die at the wrong time, in the wrong place, and alone. Next. So what are the tools and skills we need to have such advanced care planning conversations? Most of us are very well aware of the Serious Illness Conversation Guide, and this has been COVID-19 tailored and can be found on the Ariadne Labs website. We also have that, I believe, on the BC Renal website. Video has been prepared and is posted, and that was kindly provided by the work of Wallace Robinson. He was one of the individuals, one of the professionals that developed that for Providence Health. It's excellent, and it uses the tailored serious illness conversation. The BC Centre for Palliative Care website is a great resource as well. And Dr. Morgan Lamb, who many of you will know, is a nephrologist in the community as well as a palliative care physician. And he has developed and posted a video supported and sponsored by Pallium Canada. And there's also a tool called Vital Talk that was developed in the US, and it is COVID-19 ready communication, and it has some very useful, I'll say it's a bit more conversational and very user friendly, and it's been very effective. I've used it, some of my colleagues have used it, so I would encourage you to take a look at that. The BC Renal website is also a very good resource. Yes, we are shamelessly marketing it, I guess, but we do, of course, have the stopping dialysis resources there, as well as a COVID-19 tailored documenting your goals of care patient letter and implementation guide. And this patient letter was co-developed by members of our team, including a patient partner, and this patient partner was very instrumental in providing feedback and input regarding this patient letter. Next. So these are screenshots. Some of them came out a little bit garbled, but nonetheless, this goes to show how technology has its limitations. So if you go to the healthcare professionals section on the BC Renal website and under palliative care, tools and guidelines, you'll find this. So the letter is on the far left, in the middle is the guidance for implementation, and far right are resource for frequently asked questions about stopping dialysis treatment that came out of our integrated palliative nephrology project. Next. So what are some of our unique challenges in COVID times? Virtual visits and physical distancing. So we've all encountered this. So now our rounds in the hemodialysis unit, the in-center units look very different. At the foot of the bed, when you're having to raise your voice, there is no privacy. So it is very difficult to maintain privacy and confidentiality, particularly when discussing sensitive topics such as advanced care planning and goals of care. We risk losing some sensitivity and authenticity, possibly. And we must remember, for our Indigenous patients, they are influenced by previous experiences with epidemics. So we must be sensitive to this, and we need to use a trauma-informed lens. And there are some very good webinars regarding cultural safety in COVID times that have been produced by UBC, and I've had the opportunity to view some of them, and they're very helpful. There's lack of sufficient time. This is a common theme, and inability to engage all members of the healthcare system simultaneously. However, Zoom platforms may help to overcome this. This no visitor policy has been a real bugbear. So for patients facing imminent end of life, it's awful for them to be alone. But what we have found is that this is somewhat negotiable if patient is confirmed COVID negative, and visitors are very diligently screened over the telephone, actually even prior to entering the hospital. We can negotiate this point sometimes with staff and managers. Next. So the service model of care delivery, where there's a different nephrologist looking after the acute care patients week to week. So you may be in the position as a nephrologist of meeting a patient or family for the first time, and the primary nephrologist is maybe peripherally involved but not available on the front line. It takes time to establish a trusting relationship. And if there are other clinicians involved, other subspecialists, the messaging from them may be discordant, and it may lead to confusion and mistrust. Some practical tips that I've learned personally in transitioning now to this service model, where previously our group had the primary nephrologist model in terms of following our inpatients. It really helps to take time to get to know what's important to the patient and to connect with family members whenever possible. Communicate clearly and frequently with the interdisciplinary team so that you're all on the same page, including the primary nephrologist. And above all, remember to maintain the art and humanity in our practice. Next. So finally, I'd like to introduce a new project that we've been working on, and that is dialysis resource optimization, or otherwise maybe more commonly known as allocation. This is an ethical framework And the purpose is to assist dialysis healthcare providers in determining what type of care each patient will receive in the event of a pandemic, when the need for staffing or other resources may exceed available supply. And the scope involves the adult population. It's focused on hospitalized patients with acute kidney injury in both critical care and non-critical care locations. And this may be AKI associated with or not associated with COVID-19. And we also consider the impact on our chronic hemodialysis population that this may have. And I use the term robust loosely, sorry Adeera, but we think this is robust because we're using well-established, accepted, standardized ethical principles in our framework to guide decision-making. And Nina Prito is an ethicist with PHSA, and her, along with Alice Varani, have been very helpful in guiding us and giving us an ethical lens as we proceed with this. Next. So in conclusion, advanced care planning discussions should be integrated into the routine care of all patients with CKD. This does not change in the context of COVID-19. However, this pandemic heightens the importance and urgency of this. Our patients value relational, continuous, consistent, and ethical care now more than ever. Thank you.
So thanks, Gaylene, and thanks to everybody for participating. That was a lot to get through in an hour, but I think each of the presenters gave a lovely overview. There were some questions that we were answering in real time on the line. It's almost the bottom of the hour, and appreciate that there may not be time for additional questions, but are there any burning ones from the audience that people want to ask? You can just unmute yourself. Alternatively, just given that I know that people do need to get on with their day in its altered form, do go to Thought Exchange. It's a thought and questions about your response as a renal network, and you can scan that, whatever it's called, on the right-hand side. The important thing here is this is a new platform that we're trying to sort of share in real time. You can ask questions, send them directly to me or any of the speakers, and we'll try and field them. I think we're trying this platform and a more open, not that it was ever closed, but a even more open way to discuss issues and problems with each other. The medical directors in each of the regions, as well as their administrative leads, are more than happy to help answer your questions. I think mostly we have done very well in this province. We have, as a renal community, kept our patients and our staff safe. We have continued to try to deliver the best care possible in unusual situations. And I think it's a testimony that so few of our patients who are at very high risk have gotten COVID. If you've looked at the Ontario, Quebec data, there's been huge breakouts in a number of the dialysis units, and it's been quite problematic. So with that, I want to thank all of the speakers, all of the teams in all of the areas, and I look forward to your questions going forward, your suggestions for other topics going forward, and we will let you know whether we're going to have one next week or rather wait a couple of weeks, give you guys a rest from a 7:30 Friday call, and then start up a new series in June. So again, everybody, thank you for your attention to the speakers and for all that you do.